Okay, continuing on the head and neck anatomy part. So the next area would be the muscles of the temporal region. And the question is asking about the muscle that help open the mouth. And this, I remember about the DGLM, so the DLGM. So D is digastric muscle, G is geniohyoid muscle, and lateral pterygoid muscle and mylohyoid muscle. So if you look here, we have that big muscle on the background right there. So this is called the mylohyoid muscle. Okay, let me just get a blue color. I think this is, yeah, that's the mylohyoid muscle. And it arises from a mylohyoid line just in the mandible. So this is the mandible. And then inside from its name, all of them go to the hyoid muscle. All right. So these are called the suprahyoid muscle. Okay. Suprahyoid muscle. And we have another group that we're going to come back to it later. It's called the infrahyoid muscle, which is down there. So starting by this one, this is called the mylohyoid muscle, inserts into the hyoid bone. And the nerve supply to it is, again, from the name, is called the mylohyoid nerve as well. So mylohyoid nerve as well. And this is a branch from the inferior alveolar nerve. Okay. The other muscle here, which is this muscle, that is called the digastric muscle. And as you see here, so this is the digastric muscle. As you see, so it's a flesh part on this side, and then suddenly it's a tendon down there. And then there is a sort of like a ring in here, and connect it with another flesh part and the tendon. Okay, so you have here two bellies of the digastric muscle. So digastric muscle has two bellies. You have the anterior belly of the digastric muscle and the posterior belly of the digastric muscle. So let's talk about the insertion first. So it's a common tendon that inserts into the hyoid bone. Okay, you have the anterior belly, which is coming from a fossa down there in the mandible. Okay, and posterior belly comes from the mastoid notch. Okay, mastoid notch, and they all insert into a common tendon down there. And the nerve supply, again, is divided. So anterior belly is very closely related to the mylohyoid muscle. So it will take from mylohyoid nerve. The posterior belly, very close to the another muscle called the stylohyoid muscle. So it will take from a digastric branch of the facial nerve. So it takes from digastric branch of the facial nerve. Okay. So looking at the stylohyoid muscle, from its name, it's coming from the styloid process and insert into the hyoid bone, nerve supply from the stylohyoid branch of the facial nerve as well. Okay, so when you're on this side, we're talking about the facial nerve. On this side, talking about facial nerve. This side, we're talking about mylohyoid nerve. There's another muscle which is called genioglossus muscle, and it's attached to the tongue. That's why it takes a nerve supply from the hypoglossal nerve, which supplies all the extrinsic and intrinsic muscles of the tongue. All right. So these are the suprahyoid muscle, and their action basically they even drop the mandible down or elevate the hyoid bone up. Okay, just very simple. Muscles of mastication. So you have muscles of mastication, temporalis muscle, and masseter muscle, medial and lateral pterygoid muscles. All right, medial and lateral pterygoid muscles. What are the blood supply of the temporalis muscle? So very quickly, blood supply. So we're going to talk about the skin overlying the temporalis and the temporalis itself. So the temporalis itself will take blood supply from the external carotid artery, and that will be through the branch is called deep temporal artery. Deep temporal artery. On the other side, the skin takes from superficial temporal artery, which is one of the two tendon branches of the external carotid artery. All right. So next part is so we talked about muscles of mastication, and yeah, so it's basically we said the same. So I think this is a repeated question. So sorry for that. So the neck muscles, we mentioned the suprahyoid muscle, and we talked about the origin and insertion and so on. Remember the mylohyoid muscle and the geniohyoid muscle and the stylohyoid muscle and the digastric muscle as well. And it's the same diagram in here, but a little bit closer look. So I think we covered this area just very quickly. So mylohyoid muscle coming from the mandible in the line, set in the hyoid, take from mylohyoid nerve, which is branched from inferior alveolar. On the other side, you have geniohyoid muscle, the mandible and the mental spine, go to the hyoid bone and takes from hypoglossal nerve, suprahyoid muscle from, stylohyoid muscle, styloid process into the hyoid bone, facial nerve, which is a stylohyoid branch, digastric muscle, two bellies, anterior belly, arise from the anterior surface of the mandible, internal surface of the mandible, posterior belly, mastoid notch, and then insertion, hyoid bone nerve supply, which takes about the nerve to mylohyoid, and then posterior belly, digastric branch of the facial nerve. Okay, the action works with infrared muscle, like we said, elevate the mandible, elevate the hyoid bone and depress the mandible. Okay, so next part is a quite common topic, whether for medical school or generally the higher exams like MRCS or in different exam. So you need to know the boundaries of the triangles of the neck and sometimes the content of these triangles as well. So triangles are generally classified into anterior and posterior triangle. And the main, if this is the mastoid process, and if this is the clavicle and attached to the, obviously the uh, sternum. Okay, so you have a muscle in here coming all the way down, which is called the sternocleidomastoid muscle. So anterior to it is the anterior triangle, and posterior to it is the posterior triangle. Okay, so moving forward, so again, yeah, this is the sternocleidomastoid muscle, starting from this one, sternocleidomastoid muscle, and obviously it's coming from the outer surface of the mastoid process, and they're inserted by two heads. You have a sternal head and the clavicular head in here. Okay, sternal head and clavicular head. There is a small space between them, as you can see down there. Okay, so anterior to it is the anterior triangle, and posterior to it is a posterior triangle. So what about the boundaries? So let's talk first about the anterior triangle. You have anteriorly, it's the midline, just an imaginary line in the midline, and superiorly, you have the mandible all the way up. Okay, sorry, and the posteriorly, you have the anterior border of the sternocleidomastoid muscle. So this is the anterior triangle of the neck. However, this triangle is divided into four subtriangles, starting from this important muscle, digastric muscle. So right there. So this is the digastric muscle, anterior and posterior belly of the digastric muscle, right there. So it will divide it into triangle above it and triangles below it as well. However, there is another muscle as well, which is a very important muscle as well, called omohyoid. It's a critical muscle. So you have part from here, that's the superior belly of omohyoid muscle, and another part there, the inferior belly of omohyoid muscle. Okay, so let's look at how many triangles do we have now. So you will have a triangle in here. So this is, it's just below the mandible, so it's called submandibular triangle. You have a triangle in here, which contains lots of muscles. We call it muscular triangle. You have another triangle in here, which mainly contain the carotids. We call it the carotid triangle. And another one, a very small in here, is called subtriangle. It's called submental triangle as well. Okay, so four subtriangles in the anterior triangle, and we know it's divided by the anterior and posterior belly of digastric muscle and the superior belly of omohyoid muscle. Okay, so now we can say the boundaries of each of these triangles. The subdivisions of the anterior triangle as well. And also, you can, if you look at the posterior triangle, you can see that this is the inferior belly of omohyoid muscle dividing into two triangles, which is, this is the occipital triangle, just above it, and below it is the clavicular triangle. All right, so okay, so starting by the borders of the anterior triangle, like we said, midline in anteriorly, and sternocleidomastoid posteriorly, and the mandible superiorly. The subtriangles, we mentioned the submandibular triangle, and we can name the boundaries for the submandibular triangle. You have the anterior belly of digastric and posterior belly of digastric, and also the the mandible superiorly as well. So you have the mandible, the anterior belly, and the posterior belly, just like that. So, and it contains mainly the submandibular salivary gland and some submandibular lymph nodes as well. The facial vessels, artery and vein, which will be just anterior. If you have masseter muscle, you will have the vein and the artery just anterior to it. You'll have a nice diagram that will be shown in a bit, and also the hypoglossal nerve. So you have the uh, submandibular gland, which is deep and superficial part, and you have the hypoglossal nerve, which is found in between the deep and superficial part, in addition to the facial vessels, so facial artery and facial vein as well, and some lymph nodes just present all the way around. So these are the contents of the submandibular triangle. Okay, so looking at this one as well, so it's even further division. So you have here, this is the mylohyoid muscle, digastric muscle, and the posterior belly of digastric muscle will be right there. I think this is from Teach Me Anatomy. You will have here, that's a triangle containing submandibular salivary gland, submandibular lymph nodes, and so on. That's a submental triangle. The boundaries for it is anteriorly the midline, and posteriorly, anterior belly of digastric muscle, inferiorly is the hyoid bone, and it contains mainly the floor is formed by the mylohyoid muscle. You have the carotid triangle. The carotid triangle boundaries will be again is and if you go back to that nice diagram, so this is the carotid triangle. Anteriorly is this muscle, which is the superior piriform hyoid muscle, posteriorly cleidocmastoid muscle, and superiorly part of the hyoid bone, and the posterior digastric muscle as well. And it contains the carotid sheath containing the internal carotid artery and part of the common carotid artery, and the vagus nerve as well will be there. Okay. In terms of the last triangle, which is the muscular triangle, remember the boundaries is hyoid bone superiorly, midline anteriorly, and also lateral on both sides. You have the superior piliform hyoid muscle, and the inferior is the sternocleidomastoid. If you go back again, so that's the muscular triangle. You have this one and this one. So sternocleidomastoid and superior piliform hyoid and midline anteriorly, and the hyoid bone in this area. It's not actually a triangle. It's sort of coming in the way like that. All right, if that makes sense. So it's not really a triangle, and it contains all the suprahyoid, the infrahyoid muscles, and we will explain them in a bit. Okay, because it contains the strap muscles or infrahyoid muscle. These are the infrahyoid muscle. You have they come from the sternum, so you have a sternohyoid, sternothyroid, and thyroid muscle as well. Okay, so this is the muscular triangle, and like I said, it doesn't look like a triangle. It's sort of that shape. Okay, great. Finally, the posterior triangle. This is a very nice diagram as well from Teach Me Anatomy. So you have here this is the boundaries, posterior border of the sternocleidomastoid, and part of the clavicle, middle third of the clavicle, and also the anterior border of the trapezius muscle posteriorly, and it contains the inferior biliophomohyoid muscle divided into two further triangle. So that's one, and that is two. Um, so I mentioned the boundaries, sternocleidomastoid, trapezius muscle, middle third of the clavicle, and the apex is mating of the sternocleidomastoid and trapezius muscle. It contains the anterior, middle, and posterior scalenus muscle, and levator scapula, and scapetus is splenius capitis as well. So it's all these muscles. So you have your splenius capitis and scalenus anterior, scalenus medius, and the scalenus posterior, and also another muscle which is the levator scapula, which will be this yellow bit. Okay. Divided, like we said, inferior biliophomohyoid muscle into occipital and subclavian triangle, or the clavicular triangle. Contains some nerves, accessory nerve, phrenic nerve, brachial plexus, cervical plexus, vessels, external jugular vein, and subclavian artery, and muscles, like we said, all the muscles, and lymph nodes, supraclavicular lymph node, and occipital lymph nodes. These are the contents, all right? So we're going to come to explaining all the, so you have here the spinal accessory nerve, you have your greater auricular nerve as well, and it contains the brachial plexus between the middle and anterior scalenus muscles, and also the phrenic nerve, which comes from the part of the brachial plexus, C4, 5, and 6, and vessels like say jugular vein and subclavian vein. Okay, so you have the region drained by something called preauricular lymph node. If this is the auricle, right? If this is the auricle, and that will be the tragus on both sides, and you have here this is the mandible, all right, and just a crooked diagram. So that's the mandible. So the lymph nodes in this area will be external surface of the ear and the external auditory meatus as well, and the external auditory canal, and also the upper half of the face, and it takes part of the gum as well, and the area over the parotid gland. Okay, so that will be the lymphatic drainage by the preauricular lymph nodes. This diagram is basically to try to identify if there's any cancer in this pathology or not. So if you have hyperchromatic lesions such as these brown things, so this looks like metastasis from somewhere else. It looks very brown, so it's stained as well, and it looks like malignant melanoma from lymph node metastasis. Okay. I'm not sure why is it malignant melanoma, but that's the key answer for it. So I'm quite unsure why it's malignant melanoma, but it definitely looks like it's cancer. But I'm unsure why it's malignant melanoma. So next is the thyroid gland. So we're going to go through now the thyroid gland and also the parathyroid gland. And finally, we're going to take the larynx and its muscles and the nerve injury related to it. And then that will be the end of this video. We'll continue in the series of head and neck. Okay. So looking at this very nice diagram, which is from the Netter's book. So you have here the thyroid gland, as you see, it's right there. This is part is called pyramidal thyroid, which is coming out of the thyroid gland. That's the thyroid isthmus in the middle, and you have the loops of the thyroid gland on both sides. It clearly specify the blood supply and the parts of the thyroid gland. So if you look here, you have this bit is the external carotid artery, and it gives a branch in there that's going down to supply the thyroid gland, and this is called the superior thyroid artery. Okay, so this one is the superior thyroid artery on one side. Okay. Great. So superior thyroid artery and vein is specified on this side. Okay, this is the superior thyroid artery. So when you mention the blood supply, we need to specify that it is arterial and venous blood supply. Arterial is basically superior, and it's a branch of the external carotid artery. Okay, and the other side, when you look from below, so there is the inferior thyroid artery, and as you can see, it's coming up from here, and this is called the thyrocervical trunk, which is right there, and it's a branch from the subclavian artery, which is right there as well. So we have the inferior thyroid artery, and it's a branch from the thyrocervical trunk, which is a branch from the subclavian artery on both sides. So this is the arterial supply. There is an extra branch that might come from the aortic arch, and it's called thyroid artery. Which is a branch from the carotid arch. In terms of venous drainage on the other side, instead we have here superior and inferior. So we'll have superior and inferior as well, but there is a middle thyroid vein. Both of those will go into the the internal jugular vein. As you can see here, this is the internal jugular vein. You have this one, that small one right there, is the superior thyroid vein. And this is the middle thyroid vein, as you can see here, and that is the inferior thyroid vein, as you can see, is going all the way down to the brachiocephalic vein on both sides. Okay, there's another one here for brachiocephalic vein. So you have superior, middle, and inferior thyroidal veins. Like I said, this is a pyramidal loop, and it's often absent. But it's considered like as a congenital abnormality, but it doesn't cause troubles for the patient. These are the blood supply of the thyroid gland on the parts. So you have the lobes and the isthmus and sometimes the pyramidal thyroid in some patients. Okay, so blood supply, we mentioned arterial and venous blood supply. We covered the whole area. Lymphatic drainage, so you are in the neck. So that will be the pretracheal lymph nodes and also the deep cervical lymph nodes and the superficial cervical lymph nodes and also maybe prelaryngeal lymph nodes as well. So prelaryngeal, pretracheal, and paratracheal lymph nodes as well, and upper and lower deep cervical lymph nodes and precucephalic lymph nodes. Embryology, it usually arises from a foramen called foramen cecum. And this foramen cecum is between the anterior and posterior third of the tongue, all right? And then goes all the way down with the duct of the thyroid gland. And then with time, this duct will obliterate until it reaches where it locates normally at C4 to C6, okay? So it's quite important to know the embryology for the congenital abnormality that might happen later on. So in terms of abnormalities, we have one of two things. Whether there is a problem with descending down, so problem with descent, that's one, or problem with obliteration of this duct. So the descent, it might be stop somewhere in between. So it might happen, you have lingual thyroid, so it's located in the tongue basically, or pretracheal thyroid, or prelaryngeal thyroid. And also you might have the pyramidal thyroid, which we mentioned earlier as well. The problem with obliteration, so I mentioned the duct should be obliterated, but if it's not obliterated, it will lead to cyst formation. So we call it a thyroglossal cyst or thyroglossal duct cyst. So these are the abnormality, problem with the descent or problem with the closure of the duct. Level is C4 to C6. And why do thyroid gland move with deglutition? So thyroid gland is contained in, like with it, in the pretracheal fascia. And this pretracheal fascia is attached to the hyoid bone. Look here. So this is the hyoid bone. There will be a fascia containing all of these structures attached to the hyoid bone in there. Hyoid bone have loads of muscles that we mentioned earlier, the digastric, the mylohyoid, and all these muscles on this side, the strap muscles or the suprahyoid muscle. Okay, the pretracheal fascia is a quite tough structure containing all of those. So during deglutition, these muscles will contract, pulling up the hyoid bone, and that will consequently pull up the thyroid gland as well. That's why it moves with deglutition, because it's contained in the pretracheal fascia. So the nerve injury with thyroidectomy, so that will include, we need to have a closer look at this diagram once again. So you have here a few nerves, which will be the yellow structures in there. So obviously you have on the outside phrenic nerve, but it's not closely related to the gland, so we're not worried about this one. However, here you have the vagus nerve, which is this one, okay, and on the other side as well. And you do have the recurrent laryngeal nerve. And as we might know, the recurrent laryngeal nerve on the right side, it makes its curve. So it's a recurrent, so that's why we call it recurrent. So right there. So it makes its curve on the subclavian artery. And on the right side, it makes the curve on the aortic arch. Okay, so and then goes all the way up. So as you can see, the recurrent laryngeal nerve is close related to the inferior border of the thyroid gland on both sides. Okay, on the top you have here quite big nerve in there that's called the superior laryngeal nerve. And you also have the external laryngeal nerve. Okay, so external laryngeal nerve. So superior laryngeal nerve, it gives two branches, as you see here, the superior laryngeal and external laryngeal nerve. Superior laryngeal nerve gives external laryngeal nerve and internal laryngeal nerve. So as you see, external laryngeal nerve goes all the way down, so related to the upper pole of the gland. Okay, So the nerve injury could be one of two things. You either have the recurrent laryngeal nerve injury, that would be closer to the lower border of the gland, and the external laryngeal nerve injury, and that would be related to the upper border of the gland. That's why when you do your dissection during surgery, you need to make it as you go down. So, for example, on the top, make it very close to the gland, and as you go up. Sorry about that. Yeah. So, well, not really up and down. When you make the dissection of the gland, you need to, on the top, make it very close to the gland, and on the bottom, again, very close to the gland rather than away from it. Because if you go away from the gland, on the bottom, you might injure the nerve. All right, injure the nerve. So these are the rationale of doing this. Okay. So you have external laryngeal nerve injury, and we'll mention what will happen. I mean, we can mention the function of each nerve now, and then we can elicit the consequences of the nerve injury. And the recurrent laryngeal nerve injury as well, close to the inferior border of the gland. This is close to the superior border of the gland, and this is the inferior border of the gland. And also you have the cervical sympathetic chain, might be injured as well, specifically with ligature of the inferior thyroid artery. An interesting fact about inferior thyroid artery, it gives branch to this cervical sympathetic chain, and most important as well, gives branch to the inferior parathyroid gland. Okay, so one of the reasons why thyroidectomy patient can get hypocalcemia due to ligation of this nerve, and I think we're going to cover this question as well. Okay, we're going to mention the structures that are supplied by external laryngeal and recurrent laryngeal now, so we can find out what will happen when these nerves are affected. Okay, so we're just going to skip for a bit now. So again, we can cover in detail the nerve supply. Remember, the recurrent laryngeal nerve is right there, and it goes all the way up from the vagus in both sides, and it supplies basically all the muscles of the larynx except the cricothyroid muscle, which is supplied by external laryngeal nerve. Okay, and the also supplies the sensations below the vocal cord. Okay, on the other side, so this is the recurrent laryngeal nerve. On the other side, if you remember, we mentioned the superior laryngeal nerve, which is this one, and it gives the internal laryngeal nerve. This is the internal branch, and the external laryngeal nerve. This is the external branch. So external laryngeal nerve, we mentioned that it supplied the cricothyroid muscle. And the internal branch, this supplied the mucosa or sensory above the vocal cords. So what can happen if you have nerve injury to the external laryngeal nerve? Not much really, it's just hoarseness of voice. On the other side, the recurrent laryngeal nerve, it supplies most of the muscles for the larynx. That's why you might have a little bit more injury, and it really depends on which part is affected and of the nerve. Is it unilateral or bilateral, or is it partial or complete? So I prefer to mention it's partial or complete nerve injury rather than unilateral and bilateral, because partial remind me that it is mainly respiratory with a P. So if it's partial and unilateral, so that would be patient complaining of shortness of breath. If it's partial and bilateral, so it's basically respiratory compromise, and this is an emergency. All right. And again, we're going to mention this in a little bit more detail, and it'll be very clear with some images in a minute. Okay. So with complete, again, could be unilateral and bilateral. So complete, we're talking about phonation here. So complete unilateral, hoarseness of voice, and bilateral aphonia or complete absence of voice. But here, very quickly, the motor nerve supply, recurrent laryngeal nerve, it supplies the cricothyroid muscle, like we mentioned, external laryngeal nerve, all the muscles except cricothyroid muscle, which is supplied by external laryngeal nerve. Sensory, we mentioned above the vocal cords, internal laryngeal, below the vocal cord, recurrent laryngeal. Okay, so recurrent laryngeal nerve injury, you mentioned partial. So partial, we're talking about respiratory. Could be unilateral, dyspnea, bilateral, respiratory compromise. Complete, we're talking about voice, hoarseness of voice, and aphonia, and absence of cough as well. Okay, I'll leave this in a minute. That will even explain more the sort of the nerve injury. But I'll leave it in a minute after we finish the thyroid and parathyroid glands. Okay, so another question mentioned the medullary carcinoma, cell of origin. So usually it's the medulla, all right, from its name. So medulla, which comes from the parafollicular C cells, and these secrete the calcitonin. Okay, where does the papillary thyroid gland, papillary thyroid cancer? Sorry, that's not gland. Papillary thyroid cancer is spread. It's the only cancer that can get lymphatic spread. Only thyroid cancer that can get lymphatic spread. Late complication of thyroidectomy. We sort of mentioned this. So obviously, removing the thyroid gland, patient can get hypothyroidism. And we might remove the parathyroid gland and we might leave them. Okay, so parathyroidectomy as well. So the patient might have hypoparathyroidism with hypocalcemia. And finally, if you didn't remove the thyroid gland, if you done some sort of ligation of the inferior thyroid artery, you can still do like functional parathyroidectomy due to ligation of the inferior thyroid artery, which we mentioned earlier. So hypoparathyroidism and hypocalcemia. Okay. Parathyroid gland. So these are 4 glands, 2 in each side on the posterior surface of the thyroid gland. So there is one parathyroid in there, another one in there, another one in there, another one there. Okay. So the blood supply for parathyroid gland, as you see clearly from here, this is the subclavian artery. It gives the thyrocervical trunk right there. And this is the inferior thyroid artery. So the inferior thyroid artery supplies all the parathyroid glands, specifically the inferior ones as well. But generally, the inferior ones are supplied by the parathyroid gland, by the inferior parathyroid glands are supplied by the inferior thyroid artery from the subclavian artery of the thyrocervical trunk. So we mentioned there are 2 on each side, and posterior surface of the thyroid gland, hormones secreted usually parathyroid hormone from the cortex and calcitonin from the medulla, and also the embryology of this gland. The inferior will take from the 3rd branchial arch, and the superior take from the 4th branchial arch. Blood supply, we mentioned it mainly from the inferior thyroid artery. The larynx, we mentioned the nerve supply of the larynx, which could be motor and sensory. And motor is all the muscles except cricothyroid, and sensory is above and below the vocal cords. So above the vocal cords is internal laryngeal, and below the vocal cords is the recurrent laryngeal nerve. Okay, so attachment of vocal cords. This is quite a tricky one. So you have here, if you look at this, so this is the thyroid cartilage in the front, right? We're looking from above, as you see here. So thyroid cartilage in the front, and you have a retinoid cartilage in anterior, posterior, okay? So you have a thyroid cartilage and a retinoid cartilage. So this is anterior thyroid cartilage, and you have a retinoid cartilage, which is posterior, as you see here, okay? So you have the muscles attached between these cricoid and, these retinoid and thyroid cartilage. So you have posterior cricothyroid. This one muscle is called posterior cricothyroid muscle in there. And you have a muscle called thyroarytenoid. So it's basically between the thyroid cartilage and the arytenoid cartilage posteriorly. And this muscle called vocalis muscle. To be honest, don't bother with the names for now. So we have two posterior cricoarytenoid muscle, and these muscles usually open the vocal cord. Okay, 2 posterior cricoarytenoid muscle, and these open the vocal cord. and you have two lateral cricoretinoid muscles as well, and these are close the vocal cords. Okay, great. So these usually supplied, all of them supplied by the recurrent laryngeal nerve. So if you have a unilateral, recurrent laryngeal nerve injury, could be partial or complete. So if it's a partial, you remember the unilateral, that we always hate the partial because it makes respiratory. So what will happen if you have like partial affection of the posterior cricoid muscle, which usually open the vocal cord. So what will happen? There is compensation by the lateral, which will close the vocal cord. So this will be closed a little bit. If you look at this one, this will be a little bit closed, coming in here. So that's why the patient will have sort of shortness of breath, because the area of air entry is only half of it. Okay. What if it's bilateral and partial? So the posterior cricothyroid will be affected. That will lead complete closure of the vocal cord, and that will lead to respiratory compromise. So that's why we hate the partial, because partial is respiratory compromise. Partial could be unilateral or bilateral. Bilateral, complete closure of the vocal cords, and this will lead to respiratory compromise. Unilateral will lead to shortness of breath. The other side, if you have complete, instead of rupture, partial is complete now, right? So we're talking about sort of complete paralysis of the nerve. So complete could be unilateral. So let's say you have a recurrent laryngeal completely paralyzed. So this muscle, which is the lateral cricoretinoid muscle, this is the cricothyroid, sorry. So you have the lateral cricoretinoid muscle and also the posterior cricoretinoid muscle affected. So if they are affected, this will be completely paralyzed and it will stay open. Okay, completely paralyzed and stay open. So you still have, this one is working. So the patient will have sort of phonation, but the voice will be hoarse, like hoarseness of voice. It's bilateral. So these vocal cords will stay just not moving at all, not making any sort of movement. So it'll be lack of phonation and lack of cough as well. Patient is unable to cough. Okay. So these are the muscles of the vocal cord. So you have two posterior cricoretinoid muscle. In the posterior, open the vocal cord. The P goes with the P. And two lateral cricoretinoid muscle. And these close the vocal cord. And finally, two cricothyroid muscle, which is responsible for tensing the vocal cord. Again, if the cricothyroid muscle are paralyzed, it will lead to hoarseness of voice as well. Okay, and this is due to laryngeal nerve injury. Attachment, we mentioned anterior thyroid cartilage, which is there, and posterior aretinal cartilage, which is there, and lateral, it goes to the laryngeal muscle. So this is the vocalis muscle, and also this is the laryngeal muscle. So that's not for medial, it's a free border. Okay, so these are the attachment and the nerve supply and the nerve injury as well. Okay, this is again to further explain the action of these muscles. So you have here the action of the cricothyroid muscle, which we said tensing the vocal cord, cause sort of tension on the vocal cord. The lateral cricothyroid muscle, we said they close the vocal cord, so they will come together. So if this is paralyzed, it will not close, it will stay open, so it will affect the phonation rather than the respiratory. Okay. The action of the posterior cricothyroid muscle, which is right there. So we said posterior, they will usually open, okay, the vocal cords, and as you can see, they are wide open there. That's why if the posterior are paralyzed, it will not open anymore, and this muscle, which is the lateral, will dominate and will cause closure. If it's bilateral, will lead to respiratory compromise, which is this one, respiratory compromise, and if it's unilateral, it will lead to sort of shortness of breath. Okay. So we went through as well the recurrent laryngeal nerve injury, and we explained it in detail. So in this diagram, we need to identify a few structures. So let's find out. So obviously you have here number 25 is the parotid gland. 30 is the sternocleidomastoid muscle. 13 is the great auricular nerve, which is a nerve just on top of the sternocleidomastoid and supplies all the sensation lower part of the ear and the skin over the parotid gland, and the skin over the angle of the mandible, and all these areas. Okay. Number 19, which is a big nerve in the posterior triangle, which is called the spinal accessory nerve. Number 11, spinal accessory nerve. Okay, great. 41 is the posterior boundary of the posterior triangle, and that will be the trapezius muscle. Well, let's talk about some vessels in here. So one useful tip for identifying the vessels on the cadaveric images is usually the artery will appear sort of white, a little bit white in structure. So number 7 looks like an artery. And the reason why during dissection we inject these arteries with transparent dye, and the vein we inject them with a little bit darker dye or blue dye, as you can see here. So 17 will be a vein, 28 will be a vein, 12 will be a vein, 11 looks like an artery because it's white in structure, even 9 looks like an artery as well. So yeah, let's identify those. So you have a big artery in the root of the neck, so this is the common carotid artery. It will go all the way up, as you see here, and this is number 9. The only one that you can see from the lateral side will be the external carotid artery, because usually the internal carotid is anteromedial, so it will be sort of hidden. You have to go from the anterior surface to find the internal carotid artery. Well, 11, so 22 is the masseter muscle. There is an artery just on the anterior border of the masseter muscle, and this is where you palpate it or feel this pulse of the facial artery. So 11 would be the facial artery. Okay. Closer to the facial artery, there is a darker structure that looks like a vessel. So this is facial vein. Okay. So 28, that will coming from the parotid gland, it will be the retromandibular vein. Retromandibular vein. They join together and join the internal jugular vein. So 17 is internal jugular vein. So these are some venous and arterial structures in this area. We mentioned 25 at the parotid, so 33 looks exactly like it, but just below the mandible. So this is submandibular gland. Okay, 3 is a muscle coming from the mandible and going all the way down to the hyoid bone. So this is the digastric muscle, and that's the anterior belly of the digastric muscle. 26, which is here and there. So this is the platysma muscle. Platysma muscle as well. 15 looks like the hyoid bone. Below the hyoid bone, you have multiple muscles, the trap muscles. So let's identify them. You have a very long one and more anterior, number 31. That will be the sternum. It's coming from the sternum and going to the hyoid bone, sternohyoid muscle. 32 is going from the sternum to 24. So 24 is the thyroid cartilage. So 32 will be the sternothyroid muscle. The sternothyroid muscle. Well, this is the hyoid, like we said, 15, and this is the thyroid. So 38 will be the thyrohyoid muscle. 34, you have this is the superior belly of omohyoid muscle. Again, from the hyoid bone all the way down with the central tendon in there. This is what divides the anterior and posterior triangle into further subdivisions. Okay, and we mentioned it earlier today. Yeah, I think these are most of the structures on this dissection. Okay, thank you. We'll continue in the next one.